Hi and welcome to BodyWorx Physiotherapy's top 10 musculoskeletal tests for general practice. These are 10 useful and quick tests that you can do with your patients in the clinic to help indicate whether your patient would benefit from physiotherapy input as part of your rehab. In this video series, we start at the feet and work our way up, going through 10 different tests that you can use. If you want more info specifically about any of the tests or procedures, check out the worksheet that comes with this USB. Give us a call on 4952 7033 or contact me directly at jason@bodyworxphysio.com.au. Thanks and enjoy the video. So for our next segment, we're looking at the foot and specifically the ankle range of motion through here. So ankle range of motion is really important for anything like your shin splints, plantar fasciitis, heel spurs, so any foot and leg symptoms. It's really important to check this and see what's happening there. So for this test, all we need is a measured piece of tape on the floor or a ruler. So just placing that on there. The really key measurements we want are probably 8, 10 and 12 centimetres away from the wall. So for this test, normally we'd get their shoes up. Can you just pop your shoe up for me? Okay, and so what I'm going to get Tamara to do is to put her toe on the 10 centimetre mark out from the wall. There we go. Now we want to make sure the heel stays grounded on the ground and doesn't lift off. The back foot doesn't matter too much, it can be wherever it wants. And then gently taking that knee in and try and touch it against the wall. And Tamara's a little bit tight through her calf state, so we're going to move her forward to 8 centimetres. Yep, and then we'll try that again. And we're only just getting that touch on there for 8 centimetres. So Tamara's calves are a little bit tight today. What we're looking at with this test is we want it to be symmetrical, so we want it to be the same on both sides, and we want 8 to 12 centimetres. Okay, so for our next bit, we want to look at the knee and we want to see what the stability is like. So Tamara's helping me in this section. So for this test, what we want to do is a one-leg squat. So a lot of people have heard of a Trendelenburg test where it's just removing one leg and seeing if they drop down. The problem we find is with a lot of fairly active people, the Trendelenburg test isn't very good because it doesn't give us enough information, or they're just too good for it, and it's not reflective of the actual problems they're going through, so things like walking up and down stairs and that, or jogging or running. So for this test, what we're going to get Tamara to do is facing front onto the camera, and you're going to get your patient to just say, can you do a one-leg squat for me? They don't have to go very deep. It only has to be a little squat, so just one leg squat down to about 30, perfect. Now, what we could see was Tamara there was very well controlled with it. So what we're looking at with this test is, and I'll get you to let your hip drop a little bit when you do it this time. So we're looking at whether they get any hip drop through here, whether their knee tracks medially as they squat in. I'm making Tamara do all the wrong things at the moment, coming back up. So what we do know is that if they're getting that hip drop through that movement, it's going to put increased pressure in through the lower back because we're getting that sliding effect across the lower back. It also loads up the hip, including increasing the risk of trochanteric bursitis and putting extra pressure through the hip there. And the medial knee movement also puts extra pressure down through the knee joint, as well as putting extra tension through the ITB and lateral structures through the outside part of this knee here. So it's a real common risk factor we see with patellofemoral syndrome or for meniscal injuries that we talk about when we do the McMurray's testing for those meniscal injuries. So if you're seeing that, it means there's a number of biomechanical issues with how their body's working that could be contributing to their injury. We can help work on these by strengthening up their VMO, the small muscle on the inside of the knee, and developing the strength of the gluteal muscles along with the core so that we get a nice, strong, solid movement from the hips down. We do know that any weakness in this hip area is going to increase the risk of hip injury, knee injury, and can also impact on things like your plantar fasciitis and your shin splints, because that medial movement in through the knee can't always be compensated by orthotics and by just good footwear. Hey guys, and welcome to the next part of the video. So in this one we want to have a look at knee injuries, specifically trying to assess whether there is a meniscal injury in there. So we want to assess whether we need to go conservative management or surgical management. So our surgical management's really just for those patients where the knee actually locks into place or it's repeatedly badly giving way, and that's where you could look at referring for a bulk build MRI under the Medicare to assess whether there's a severe derangement of the meniscus. So this first test is called the McMurray's, and it's just a really nice easy test to be able to see how much pain reproduction we get and if there's any clunking or symptoms with that. So with this test, all we're doing is gently taking the patient's leg fully up to the fully flexed position, seeing what they're like with that, seeing if there's any pain with that position alone, and then gently holding onto the ankle or onto their shoe and gently sweeping in with a little rotation movement of the hand and then sweeping out the other way. If there's still no symptoms and that's feeling fine, you can then rotate in and push it out into extension, and the same thing with the other way. So we're just moving, creating a little torsion, so a bit of medial torsion through there, and then pushing it out into extension, same way back out through the other way. That way what we're doing is we're really creating that gentle rotation force over the whole joint surface, and if there is any meniscal derangement, we should see a clunk or a bit of pain with that. As long as there's only a minimal amount of pain and there's, as we said, there's not that locking or giving way, the patients that report that pain, that little bit of clunking or symptoms with that test are usually indicative of someone that would respond well to conservative treatment, so physiotherapy, where we're getting them to strengthen up through their BMO, through their ITB. They may be candidates for anti-inflammatories, for prescription anti-inflammatories, if they have a lot of that joint effusion that you'd see through there. Hey guys, so welcome back to our next section of this. So in this section we want to have a look at the hip, and in particular we want to have a look at how can we see whether we think there's some internal joint derangement within the hip. So specifically if there is some impingement going on in the hip, or there's some labral issues in there, or if there's any major arthritic changes within that joint. So this test we call a quadrant test. So we gently take the patient's leg up into full flexion and a little bit of adduction. At this point some people may have a little bit of tenderness, and it's quite normal to have some tenderness in through the front part of the pelvis through here. So that's not too abnormal in itself. We then want to gently lean over the leg with our bodies, put a force down through the shaft of the femur, and gently rotate it into internal rotation, using our elbow just to create that little bit of a force. Now if you've got somebody that has a pretty bad internal derangement of the hip, they'll often get some fairly significant symptoms when you do that test, so there may be a fair bit of pain with that. It's not always 100% indicative of internal versus external impingement of the hip joint though, so it's always important to double check just with some of your other range of motion tests, as well as having a palpate to feel. We do tend to find that a lot of our soft tissue impingements will respond really well to dry needling, to soft tissue work, to stretches at home, but you know, in the end, any of those that have really clear signs of internal hip joint derangement, something that we look at, you know, needing a specialist opinion for an arthrogram or something on the hip to see exactly what's happening in through there. Welcome back to the next segment. So our next segment is looking at the lower back and a straight leg raise test. So we have two options with this straight leg raise test, so it sort of counts as two different things. So in our first one, we're doing a passive straight leg raise. What this does is we're looking at creating neural tension through the system to see if there's any limitation to the movement of the nerves between the lower back and the toe. In really severe cases, we can do this just as a passive head raise. If you think somebody's really irritable, so if they've got really bad back pain, they can hardly move, and you raise their head off the bed and you're getting symptoms down through here, you know that there's definitely a limitation to the neural system at some point, because we've only put a bit of tension on it from the head end and it's still created those symptoms down here. But for most patients, we're going to do what we call a straight leg raise. So asking the patient to stay nice and relaxed, and then we're going to slowly lift the leg up until we start to feel tension or there's an onset of pain. As a general indication, if you're getting pain below 30 degrees and severe pain in the lower back before 30 degrees or sciatic symptoms, there's a high chance there could be a disc bulge or a disc derangement in through the lower back. If it goes up to higher, it's quite normal to get up to that 60 to 90 degrees for people with reasonable range of motion. Once we're up there, if we're still not getting any symptoms, we can sensitize this by adding in some dorsiflexion of the foot, and then even adding a little bit of adduction if we really want to go searching for something. Making sure you compare it with the other side and checking. Because what we do know as well is if we get opposite side symptoms, so if their pain is all on their left side and I raise Tamara's right leg and it sets off the left-sided pain, we know that there can also be a large chance of a disc problem being there as well. So that's your passive straight leg raise. And we're really looking at, is there any limitation to those nerves being able to move and basically floss through the system when we're moving our legs. So if there's anything like joint tightness, muscle tightness, either through the lower back or the hips, that can bring on those symptoms as well as disc bulges. So it's not a pure indication for a disc bulge, it just indicates that there is some limitation to the free movement of the nerves, or there's an irritation to the nerves somewhere in that area. Our next one is an active straight leg raise. This can also be a pain provocation test, but it also requires you to check out what's happening at their hips. So when we do this, we just ask the patient to lift their foot about 10 to 15 centimetres up off the bed. So if you can do that for me now, yep. And so what we're looking at with this is, number one, is there any pain symptoms? Or number two, do we see the opposite ASIS rise up? So I'll get you to drop that leg, and then we'll watch this one. So raise this one. Tamara did pretty good with that one. Try and relax and not be good in this. Raise this one again for me. Yep, so you can see this ASIS moved a little bit. It's really hard when you've got somebody that actually has quite a good functioning back, because it means that, you know, they obviously don't show off these tests quite as well. So that's your passive straight leg raise for neural tension or something that's pressing against the nerve possibly. And then you've got your active straight leg raise, which is looking at core control. So if we see our passive straight leg raise comes back positive, that's a sign that we either need to get in and loosen some of these things up to get the nerve moving better. It's probably not an indication of an immediate referral for MRIs unless it's matched up with those other neural symptoms of that numbness, weakness, loss of reflexes, or that sock distribution of the numbness, pins and needles and pain. As far as your active straight leg raise goes, what it indicates is that that patient, if they're getting pain with that and getting movement in the hips, are a prime candidate for core strengthening work. So by improving the activation of their transversus abdominis and their pelvic floor, we can help stabilize the pelvis much better and decrease their pain and symptoms. And it's going to be a long-term thing that we have to work with them, because it's about getting them going with that program and then making sure they have the tools to keep going with that, because you're looking at about at least 2 to 3 months of them working on it to see good changes in their core strength. Next section of this video is about thoracic, so we're looking at the upper back movement. So we want to specifically here have a look at extension as well as rotation. So to test this, we just get the patient to sit over the edge of the bed, something where their legs are against the edge of it, so it sort of locks in their lower body, and then say, can you please pop your arms across your chest, and then gently turning to the right and turning to the left. And what we're looking at for normal in this test is we'd expect them to be able to come around to about 60 degrees rotation, and it should be equal on both sides, so we want that to be equal. So this is really important if you've got something like people are coming in with continual neck pain, shoulder pains, or upper back problems, things like your costovertebral joint irritations or sprains are really common if they've got a restricted range of motion with that. The next one we do is we're looking at thoracic extension. So we ask the patient to put their hands by their sides and then slowly raise their hands all the way up over their head. And what we're looking at is, can they get their arms straight up without hyperextending their lower back to get them into that position. Cool. And you can raise your arms, put your arms back down, that's it, perfect. So we want to see that they can get the extension in through the mid-back, not all through the lower back. What we know is that those two movements, both the thoracic extension and rotation, if there's a limitation there, they're common risk factors for having problems in through the neck for cervicogenic headaches, for shoulder impingement, especially in younger guys and athletes, and also for the onset of, as I said before, costovertebral joint sprains or irritations in through the mid-back here, which you'll often see presenting as pain in through the mid-back, possibly even referrals into around the chest or ribs. Next section is our looking at shoulders. So shoulders are probably one of the most common things we treat in the clinic. And it's really important to see whether we think there's any shoulder impingement, there's any structures getting caught within the actual shoulder joint itself. So I always explain it as the glenohumeral joint's here and you've got your humerus sitting up into it. And in through that space you've got your rotator cuff tendons and your bursa, little fluid-filled sac meant to protect everything in there, but sometimes it gets rubbed to the point that it's just too much. So we either see it as a repetitive irritation injury or on a one-off traumatic injury sort of thing. So what we want to check is to see whether there's any symptoms coming when we bring those two surfaces together. So there's a few different names for these tests. One of the common names that people will say is Hawkins-Kennedy as an impingement test. So with this one, we want to take the patient's arm up to 90 degrees, as long as they're not too painful being in that position to start with. Otherwise, they may be quite acute and quite inflamed with their impingement. And then taking it down towards the floor and seeing if there's any symptoms. Comparing it to the other side, because some people may be naturally a bit tight and tender in these shoulders, so if you compare it to the other side, it's the same. We don't have to worry as much. And the next part is then, if we still haven't had anything there, to get a little bit more aggressive, take the arm across in front of them, and then once again take that down. And we'll see even on Tamara, who has normal shoulders at the moment, there's a decreased range in that area. And that's because when we take it across into adduction, we're making that joint test much more aggressive. So if they're getting pain that's different on one side to the other in that, especially across this lateral or anterior section of their shoulder, it's a good indication that there's some shoulder impingement going on. If it's across the back, it means their posterior capsule is possibly tight as well. So both of those things are quite amenable to physiotherapy care. From your perspective, it would be up to you to look at whether you think there would be benefit from an anti-inflammatory to assist with the physiotherapy treatment at the time, while we're trying to loosen up the muscles through dry needling, massage, and maybe some pulsed ultrasound. Whether they would benefit from the anti-inflammatory to help settle down that inflammation that might be in the bursa. Normally we find that if we haven't had good results within those 3 to 4 weeks of treatment, that's when we want them to get back to you guys and have a chat to say, you know, what's the next step sort of thing. 4 to 6 weeks is sort of our maximum. We like to treat the shoulder impingements conservatively before we start to look at getting other opinions with ultrasounds and possibly injections or something. So for the next part of our testing procedure, what we want to have a look at is the wrists. So we want to have a look at the extension and the flexion range. So we can call this prayer and reverse prayer. So for prayer, we put our hands up like this and take them down into this position. And so what we're checking out here with the patient is that the patient can get their hands to roughly 80 to 90 degrees through that angle there. And then reverse prayer is putting the wrists together and taking the arms down. And once again, we want to see that they can get to a nice roughly 80 to 90 degree angle in here. What we do know is if you see patients that are having real trouble getting their wrists back past towards that 80-90 degrees in either direction, they may have some limitations in how their wrist joints and forearm muscles are moving. These patients are really likely to be at risk of things like your carpal tunnel and your extensor and flexor tendinopathies. So if you have somebody that comes in with some of those signs and they're really tight through there, that would be an indication that there's some areas of work that physiotherapy could help with, such as trying to do some joint mobilization in through the wrist, soft tissue releases or dry needling in through the forearms, and stretches and home exercises to work on. I hope you found that video informative and got some useful techniques that you can use with your patients in the clinic when dealing with musculoskeletal injuries. If you need any more information, please check out the worksheet that's on the USB with this video. And for more information, give us a call on 4952 7033 or email me directly at jason@bodyworxphysio.com.au. We're always happy and looking to work with local GPs. Thanks and have a great day.